Welcome to Healthcare du Jour, where we dish up and digest the latest in healthcare. For the next 30 minutes, sit back as we bring you insight, commentary, and discussion on trending topics to the table, all expertly served up by our host and his guests. Now here's your host, Matt Fisher.
Welcome back, and thank you for joining as we dive into the hottest topics in healthcare. I'm your host, Matt Fisher. On the menu today is Dr. Joel Diamond, Chief Medical Officer at Aranscia. Dr. Diamond, welcome back to the show.
Matt, it's great to be back. Thanks for having me today.
So, Dr. Diamond, as I said, this is your second appearance on the show, but I know it's been a little bit of time since you were last on. So I'll give you a chance to give more of an introduction in terms of who you are and what you do so you can remind the audience about your background.
Sure, and thanks, Matt. I'll try to keep that part brief. First and foremost, I've been practicing family medicine. I live outside of Pittsburgh. I've been doing this for greater than 3 decades now, so I always consider that my main activity. But I've been involved in healthcare IT for a good deal of my career. Started a couple companies dealing with health information technology exchange. Currently, the company that I'm with, Aranscia, is involved with genetics and genomics and bringing molecular testing to the point of care of physicians and helping them with the workflow all the way from ordering those tests to getting those results in a way that's meaningful to them at the point of care and helping them make better decisions based on genetics.
So before we start unpacking what you mean by genetics and genomics and all the testing, I know you said obviously you're a physician. So what got you interested in going into the health IT field?
Health IT is interesting. I sometimes laugh because I never thought of myself as a technologist. I was interested in using electronic medical records at an early part in my career. I couldn't believe that we were so far behind in medicine compared with other industries. And I guess I would have been called an early adopter at that point. One of the things that I was interested in when we started our EMR was to make sure that we documented things like how we're improving efficiency and how we're improving quality of care. And that sort of led to getting on the lecture circuit somehow as an expert, although I never considered myself an expert in that. But those matrices were really important because early on, it was clear that we can use this as a tool really to make some big impact on chronic disease management and other things. Just things like reminders of quality measures and gaps in cares as an example of that. Certainly, we've come a long way with that. And eventually became much more interested in how we use this on bigger systems in healthcare, how we can exchange that data and do better communications between physicians and other medical personnel.
Yeah, I think, as you said, it's certainly come a long way and, arguably still has a long way yet to go given the constant evolution. But it's, I know you said kind of in your background that, you're focused at your current company on genetics and genomics. So if you wouldn't mind, could you help define what that actually means for everybody?
Sure. So genetics, as most people knows, is the study of DNA and how it affects us. Genomics is a sort of broader term looking at our entire genetic makeup and what effects that have in terms of things like how we metabolize different drugs on one hand, which we'll talk a little bit more today. Certainly in the last several years, the explosion of using molecular-based tests to determine therapy has really, really changed medicine, probably in a way that I haven't seen in my entire career. You just need to turn on TV and see ads for drugs nowadays that end with an AB, and all of these drugs have a molecular component to them, whether we're treating migraine headaches or eczema. But the most exciting part is, in my opinion, really been the advancement in how we treat cancers nowadays, really based on those genetic components of the cancer rather than based on the anatomical location of that cancer. And really, what an amazing difference we've made in cancers that many years ago, not that long ago, we thought were incurable. And now we have lots of different hope for patients. The tricky part of that, and you say we've made a lot of advances in healthcare technology, but in some ways we've gone backwards because there's not a lot of standards around the nomenclature of cancer and other things. And applying that information at the point of care in some ways has remained stagnant or even gone backwards. It's surprising that most of those genetic reports go back to doctors as text documents or PDFs, but not as discrete data that can be used like other laboratory things in the work that we do.
Kind of thinking about how do you make that more actionable, getting those reports, are you seeing any progress on that front? And, kind of what is fueling that progress?
Well, the problem is, as you alluded to, is that the technology and the science is happening so very, very rapidly. And as usual, the problem with standards is there's just so many of them. And so we continue to have to not only adapt to new standards, but be able to do some mapping of those different standards to other clinical data, which has always been a challenge in healthcare technology, and it still exists today. And then the other piece of that is, how do you do clinical decision support and help clinicians make good decisions on what test to order or how to interpret those results? Certainly, if they're coming back as a piece of paper, it doesn't do us an awful lot of good. So that's a lot of the work that my company right now, Aranscia, is doing in terms of helping with those standards, helping mapping those standards, and helping that data be readily available within a clinician's workflow.
So I guess even before you get to that, making it part of the workflow and making it easier to utilize, I know you just said there's been a rapid advancement of standards and kind of the availability of different solutions. So kind of what is, are there certain factors that are fueling those advancements? And what are, other than, I think, as you're trying to say, hopefully getting that better mapping and presenting it in a different way, how are clinicians supposed to learn about these advancements?
And it's hard. You're right. I could look at my own training in genetics from medical school, and it was maybe a 1 week course that was added on. And then I look at how much that's advanced since that time and the amount of knowledge. There's still a very significant gap between training and application. So that continues to be a problem today. The second part of that is that the language used, both in ordering and interpreting results, is incredibly complex. It's easy for doctors to order a lipid profile or a CBC or a chemistry profile. We know how to do that. It's built into our EMRs, and we collect their part of order sets, et cetera. But the specific tests that may be necessary for treating a patient with cancer, as a matter of fact, or looking at a family history and determine whether they're susceptible to cancer or other conditions, and ordering a genetic test isn't really within that type of workflow. So there's a challenge both in the clinical decision support on what test to order, how to order it, what to do with the results when they come back, and then interpreting those results still is a wide open field today.
Yeah, and I think as you're certainly describing what sounds like a very complex environment, and it's I guess that starts to go back to maybe a point that you made a minute ago, which is with the advancement of the testing and the understanding of what it can do. I know you were using the example of cancer. You said you're not necessarily targeting a body part or the location where the cancer is, but you're now able to target the genetic makeup of the condition. So how does that change the calculus of the decision that you're making and the approach that you might take in delivering care?
Yeah, so you're getting to an interesting point. Again, I'll get back to, if you're watching TV and you see a commercial for a drug and you notice that same drug somehow treats Crohn's disease, and it treats psoriasis, and it may treat some other, what seems like completely different conditions. The same, you see drugs now to ask your doctor about a drug for treating cancer, which is always weird to have a commercial for that. But you notice that those cancers can be very, very different diseases. What we know is that cancers and other diseases with pathology alter the expression of DNA in a very individual way. Not necessarily in cancer, the DNA that we're born with, but the sort of mutated DNA that the cancer itself has. And identifying those markers has a profound effect on how we treat that disease. And as we get more and more specific, we'll get better at treating those diseases. A good example is the word breast cancer. The reason that breast cancer has been so difficult to treat is there's probably not a single disease called breast cancer. There's probably thousands of different diseases. And in fact, there's some rare cancers that when we find the cure, the reason that we do is because there's a single pathway to that disease. And that's why it's easier to treat once we find that cure. And breast cancer has made some progress over the last few decades of recognizing things like estrogen receptors or progesterone receptors or Herceptin receptors have a profound effect on both the prognosis and the treatment of that disease. There's more and more drugs that target those specific factors. And now we have an array of multitude of other genetic markers for breast cancer that determine a very, very specific drug treatment. On top of that, cancers mutate over time, and so there's a constantly evolving need to follow patients and then be able to offer them a new type of treatment if the disease is to recur or progress with time. So that's a great example of where genetics is playing such a significant role and why we're seeing such improved care, survivability, and outright cure for some of these diseases.
And it seems also inherent in what you're describing there is that and I think this is the point you're making, that you can't just apply one label to it, because it's as you start actually refining the testing and using testing that gives you a more granular view of what's occurring, you're really treating individualized cases as opposed to just trying to say it's breast cancer or pick any other type of condition. But it's, I think what you're saying is this is the genetic profile. Now let's figure out what treatment is going to work best for that profile.
Yeah, Matt, that's a great point. The term precision medicine, and for a while people were using the term personalized medicine, but it's an interesting nomenclature. When I was in medical school, there was a big move to move away from saying that each patient is unique, and we were really taught that we should bring some standards. We should look at clinical trials, and we should do treatment that was based on large scale trials, which is a great idea and still is. The problem is that the people that are more than one or two standard deviations below and above the mean, and how do we treat those? And that's where we're recognizing that precision medicine really applies to those people. We could take a more specific example like pharmacogenomics, where we're finding that certain medications may work very well for one individual, and in fact, for someone else doesn't work at all. And by the same token, a medicine may work or not work, but have profound side effects in one patient and not in somebody else. And that has to do with our own genetic differences in how we metabolize drugs. So picking a medication that works best for a patient and has the least amount of side effects has always been our goal, but now we have some tools to be able to do that in a much more scientific way.
Yeah, it's kind of, as you're saying, you have a standard as a baseline, but you need to then have information of when you're going to move away from that. And for those of you just joining, I'm talking about Dr. Joel Diamond from Aranscia, and we're talking about molecular testing and genomics and the influence on medicine. Dr. Diamond, you just mentioned pharmacogenomics, which I know you just briefly described what it is, but the way you were starting to describe it feels like that is a growing field, or at least a field with kind of growing awareness of the importance. So, if you don't mind, could you just kind of expand on what exactly that broad term encompasses?
Sure. We've known for years that people respond differently to different medications. Certainly during my training, we were taught that certain high blood pressure medicines work better in certain ethnic populations than others. And so understanding that variation in how we metabolize or respond to drugs is something that's familiar to us. Also, the concept of using drugs in a safe way in practice is something that's a nice toehold into the application of precision medicine and genetics in general. So all of us metabolize drugs in a unique way. It turns out that almost all of us have some variation that's based on our genetics in the way that we metabolize certain substances and drugs. In terms of the medications that we commonly prescribe, some of those have a profound effects. For instance, the antiplatelet drug Plavix or clopidogrel that we use pretty much universally in patients that have had a cardiac event. In some people, they metabolize that drug very, very rapidly, and they don't have any antiplatelet effects. So that drug doesn't provide them a lot of protection against having a second heart attack. In drugs, for instance, that we use to treat depression and anxiety, the SSRI class of drugs, some of those drugs have a profound difference in metabolism from individual to individual based on genetics as well. And it explains why some patients cycle through 2 or 3 different antidepressants before they arrive on the correct one. I think in 2026, we've got to stop doing this trial and error approach to that. It doesn't make a lot of sense in somebody that has been suffering from severe depression, as an example, and be told, here's a drug that may take 4 to 6 to 12 weeks before it's effective, and then find out, now let's just pick another one out of the hat and try that one. I think we owe it to our patients to use a lot more precision to try to get these medications nailed the first time around.
So kind of going in that direction, are there ways to more integrate pharmacogenetics or pharmacogenomics, I should say, into the standard of care and make it more readily available so you're not doing that kind of peck and find method?
Yeah, and I think there's a couple misconceptions that people have in this. First of all, I think traditionally the cost of genetic testing has been very, very high. And I think that's still a factor that intimidates a lot of people, when in fact, the cost of doing this testing has come down to a lot of other diagnostic testing that we do. The other piece of this is not try to force a new technology on people. I often say to people, let's look at areas where you're already focused on. Listen, adverse drug events in elderly patients, as an example, most of us know there's a list of medications called the Beers criteria, which are drugs that we know we should use with caution or not use at all in elderly patients. Many of us have money incentives from how we get paid based on whether or not we use these drugs or don't use these drugs. So introducing pharmacogenetics to those kind of safety measures is a nice starting point. The Plavix example that I talked before, when we're talking about cardiovascular disease and how to improve that overall, that's a nice entry point to this. And certainly in the field of behavioral medicine, where we know the trial and error approach, as I've discussed before, is so frustrating to clinicians and patients alike, this is a nice place to start introducing that. Not necessarily with the first-line drug, but certainly not go to a third-line drug without considering doing some pharmacogenetic testing before I initiate that.
As you're trying to weave it into the workflow that way, is there any hesitancy around concern that maybe it's not accurate or that the information isn't going to be, what was expected? And, to some degree, it sounds like maybe you were already answering that earlier when you were talking about the rapid advancement and evolution of the knowledge base. And, to some degree, it sounds like it could potentially just be overcoming past hindrances or, just re-educating on the impact.
Yeah, I think like in a lot of things in medicine, getting clinicians comfortable with that and talking about what standard of care is a certain piece of this. There are drugs that have a black box warning in their labeling that talks about doing pharmacogenetic testing. I'll give you a great example. For many years, we know that there are certain chemotherapy drugs that we give for colon cancer, as a matter of fact, that a certain percentage of people could have a life-threatening side effect of that medication. And for years, there's been a large push to do pharmacogenetic testing called DPYD testing before giving that class of drugs. It's only been in the last year that the FDA put a black box warning on those drugs that actually said you need to do that. So that will motivate a lot of people because there's a medical legal piece of that. And so those black box warnings or FDA warnings about pharmacogenetics will certainly help promote that. The other piece is there are standards around this. There are large organizations, consortiums like SIPC and other organizations that determine these standards. But we need to do a better job of communicating that to clinicians so they realize this isn't sort of a nice thing to do. It's actually part of the standard way that we take care of patients. And in fact, there are significant legal complications of not doing those things. So I think that'll be a big motivation. On the other hand, I think that we need to bring this into the workflow better. We need clinical decision support tools. So in the case of DPYD that I mentioned, we need a warning to happen in the electronic medical record when prescribing a drug that says, don't do that because you may hurt the person. And that's not an alert fatigue kind of warning. That's one where you want to be stopped dead in your tracks before you do that. In other cases, like the depression example that I used before, it may be that if this is the second or third time I'm prescribing medicine in the same class, I might want to get a passive warning that says, hey, by the way, there's a test out here that may help you with this. I don't want to stop you from doing what you're doing right now. So the smart use of alerts and clinical decision support tools within the electronic medical record, I think will help introduce those things. But we have to do this in a smart way that we're not interrupting care and slowing doctors down in their care of patients.
It also sounds like it's kind of multifactorial in terms of how you can get people comfortable with it. Because, with the example that you gave of certain drugs having that black box where by regulation, you need to obtain the testing. It sounds like maybe that's the first step to getting used to integrating into workflows. And then, with the CDS tools and the alerts that you were describing, it's kind of further reinforcing that. And it's, and I suspect there's probably other things that are out there that help raise awareness and show the impact of pursuing the testing. So it's as you start kind of combining all those factors, now the clinician is just used to seeing that the testing as an ordinary step in the prescribing and in the care delivery process. And it's, it sounds like if you can get to that state, then you've really achieved, most of the end goal.
Yes and no. And you're absolutely right. The no part of this is it's really great to convince somebody that they should do it. But when they go to do it and it's hard to do, like, how do I order that test? It's a mouth swab. Where do I do this? How do I put an order in for that? Where does it go? Those have to be fully ingrained in our workflow like everything else, because otherwise you can convince somebody to do a test. But if it's really, really hard to do, then it doesn't help. A great example of that is there's a much more awareness of looking at risk factors for breast and ovarian cancer. I think most people know that there's a genetic factor called BRCA, amongst many other genes that are associated with that. But ordering a BRCA test is not exactly something that's easy with somebody's workflow. And typically we said, well, let's refer you to a genetic counselor and they'll do that. Where I practice, the waiting list to get into a genetic counselor can be upwards of 6 months or so. And a lot of patients say, you know what, maybe I don't really want to have that. That's not something immediately on my mind. So we have to improve the whole round trip from clinical decision support to ordering. And then when we get the results, we have to make those available and bring them back to clinicians in a way that they can understand the results. Getting a result of a pharmacogenomic test that says the patient's a rapid metabolizer to CYP2C19 doesn't really mean an awful lot to me. But if you tell me, here's are the drugs that particular gene can affect, and this is how, either by too much or too little. And most pharmacogenomic reports today, as an example, can list drugs in a very simple way as green, yellow, or red. And that's a nice concept. Like, okay, the drug's okay. I don't need to know a lot about CYP2C anything, but I know that this is probably a safe drug. This is a red one. I might want to choose from a different category.
It's kind of interesting to hear you say that, where it's, even within the profession where you're dealing with professional to professional, a report might not be easy to understand. And that seems like to some degree it's a corollary to some broader discussions of writing more in plain English and, allowing everybody who sees a report to understand it more easily.
Yeah, and I think adding to that is, I was talking to a patient yesterday who had their laboratory results, not genetic results, but just regular lab results, way before I did. I was in the office this morning before we started talking, and I still don't have the results. So they're questioning about the results and little subtleties about that. The results were basically normal, but they were very, very frightened. The fact that I didn't have them in front of me when we were talking is another problem that we have. And I think putting patients at the center of their care, as well they should be, means that we also have to make it understandable to them as well as to doctors. And if it's complex for doctors, it's certainly very, very complex when we introduce these genetic components to the results that people are getting every day.
Yeah, no, that's a great point. And believe it or not, we're already almost out of time. So I'm going to ask a final question to hopefully wrap that together, which is, what would you hope are the next steps that allow this, a simpler, easier to follow process that also is creating information that is more readily accessible for everybody?
Well, the one thing I think we still have a giant leap to do in convincing people that this is now the standard of care. This is no longer emerging technology. We cannot treat cancer today without using genetics as part of the understanding of cancer and the treatment of it. You wouldn't want to go to that. And how do we get people to realize that that's already occurred? You and I would not go to a bank where somebody took a ledger off the shelf, dusted it off, and used a pen and wrote an entry into there. We wouldn't trust the bank anymore. And in fact, we are going to clinicians with all sorts of technology, PET scans and laser surgery and robotic assisted surgery. And yet the information technology has a significant lag. So I think that's the first step, is making people understand that this is here, it's now, it's not a new technology, but we need all the supporting technologies to make that work.
Yeah, no, an important development, and hopefully one that occurs, not in the not too distant future. But Dr. Diamond, as I said, believe it or not, we are out of time. So thank you for a great conversation today.
You're very welcome. It was a pleasure. Thanks for having me.
Yeah, and thank you to everyone listening. Keep the dialogue going and connect with me at #HCDEJURE. I'm Matt Fisher. Until next time.